Hello and welcome to our new podcast, which is called Happy Health Hour. And it's called Happy Health Hour because we're going to be talking about health issues every week, a different topic every week. And we will change the topic. We'll have some fun while we're talking. With me are two regular guests. I'm Dr. Nawtej Dosanjh, but I'm not a medical doctor. I'm a PhD doctor. So there's a slight difference between me and the people that you'll meet as guests. Our regular guests, Dr. Pariksith Singh, the CEO of Access Healthcare Physicians, which has about 110 doctors in the group, serving 70,000 patients up and down Florida. And joining both of us, another regular guest, the senior nurse at Access, Nurse Lynda Benson. Welcome, Lynda and Pariksith. How are you?
We're good. I'm good.
Nice to be here, Nawtej.
So I think we talked about this before. I'm not going to refer to you as Lynda and Pariksith, if that's okay. Lynda, I'm going to call you Nurse Lynda. And Pariksith, I'm really growing fond of your handle, your YouTube handle, Dr. P. Is that okay with both of you, Dr. P and Nurse Lynda?
Yes, that's fine. We're good.
Okay, yeah, excellent. So listen, this week we are going to be talking about fall prevention. Now let's get into it in a little while. But Lynda, Nurse Lynda, why don't I start with you? And the first question I have really is, why did we start an initiative called Fall Prevention? What was that all about?
Several reasons. First of all, we didn't invent it. Our government and the CDC, which is a department in the government, has been after everybody at every level of health care about falls for years and years and more years. We have the falling stars in the nursing homes. We have fall prevention in the hospitals. And we see patients, they walk into our office and they're coming from their homes and they've fallen in their home, whatever. The cost in lives and dollars is huge. And for me, I think it's a gateway. This initiative is a gateway to other initiatives. So we had to start somewhere. This seemed to be the best place to start.
Okay, so I remember when we were talking about this last year, Dr. P, you were adamant that you wanted this initiative to start, and you were very, very forceful in wanting to see some sort of initiative. When we were talking about it, how did we come to what we did? We had a questionnaire, we had a methodology, we had some articles, and I think we had some results. But before we get into the results, just talk about what the initiative outlined or comprised.
So just as a quick recap, the initiative started in my head over a few years ago when we had a physician who fell forward and he had his, it was, I think, the day before Christmas. He had gone to do some shopping right there at the front of the shop. He fell. Mm-hmm. Yeah, and he fractured his neck. He had a hangman's fracture. He was fully paralyzed and he died within the next 5-6 days. And this was a functional member of the medical community who himself fell and had a major injury. So, and we had a couple more patients after that who had fractures of the cervical spine, which is the neck, and that is the most dangerous place. And you'd be surprised how simple what we would call a not very complicated fall. These are not falls from the roof or from ladders. These are just falls while the person is standing and to the ground level, and they cause major injuries to the patients. And so obviously that was the motivation. And then we involved Lynda, and we started screening them, and I pushed every patient to start exercising with me and creating an exercise program, and then we put a structure around it.
Okay, but before that, or well, maybe after that, we actually approached it in a very clinical way. So to talk through, I mean, both of you, maybe I'll start with you, Dr. P. Talk about the questionnaire, the methodology, what the time frame, talk about how the initiative, just put the initiative together for us, and so the people, doctors and patients, understand
So,
beyond the word what it actually entailed.
so a fall is an endpoint, right? A fall is something in your whole system has gone haywire. It could be your medications, it could be your brain, it could be your heart, it could be your nerves in the feet, it could be your back of the spine, could be lack of exercise, could be balance issues, could be the B12 deficiency you have, could be some medicines you are taking, could be your bad shoes,
I
could
was
be
going to say, these
just
shoes you're wearing.
your light at night, your the floor, how it is, pets around, all these things come together and you create a fall. Now, falls are to a large degree preventable if we work uh, through the issues that a patient has. These are complex issues, but if we are able to work through them, we can prevent a fall. That was our initiative, endpoint. How do we reduce it? And I started, I didn't have a formal method. I would just start interviewing people, start talking to them, and simple tests to see how strong they are. And I started giving them the exercise programs. And then suddenly I realized most of our patients have zero exercise interest or any kind of investment in their physical well-being. These are elderly patients, but all of them can exercise 5 to 10 minutes, and that was my push.
Okay, Nurse Lynda. So, talk us through all the conversations we had about how we could really pull this together in a way that could be scaled in one clinic, multiple clinics. Because remember, obviously, if you just talk about health, fall prevention, people can go and do their own things. It's not clinical, right? It's not robust. So, we had a lot of conversations. We had a back and forth about the questionnaire. So,
Yes.
talk to us about the value of the questionnaire.
So we have many different iterations, but when we decided to do an actual study, the questionnaire that we developed the first time was meant for that study. And in order to do that, it had to be able to, we had to be able to get data from it. So it had to be set up in such a way that for each question, for each issue, we had a range of responses so that we could pull the data from it. The most important part of it was to risk stratify these patients. What was their risk for a fall? Had they already had one? Had they already had an injury? Fall without injury or a fall with injury, that automatically puts them at a moderate or high risk, depending. But then the questions that we considered had to be able to get us to a point where we could risk stratify them into, no risk, low risk, moderate risk, high risk. So a lot of thought went into that first questionnaire, but not only to risk stratify the patients, but then what do you do about it? I mean, what are their issues? Do they have prostheses? Do they have an AFO? Are they partially paralyzed? And the most important part, the way most practices work, the MA, the medical assistant, rooms the patient. The patient's already sitting and set when the doctor walks in the room, and they never see them move. So how can you ascertain what their balance is or what their function is? So we put into this, these are the things you have to look at. Get the patient up, get them to walk, take their shoes and socks off. We had to literally go through all different levels of what you needed to be looking for, what you needed to be listening to. Use all your your senses when you're actually examining the patient. So yeah, there was a lot that went into that particular
And it took
document.
and it took a bit of time, didn't it? Yeah, I remember, Linda, we were trying to put this together, and Dr. P was getting frustrated that it wasn't moving fast enough because he wanted it in 24 hours, and we said, look, we've got to make it robust. And so then what happened next? We finally agreed on the questionnaire. We finally agreed what it would comprise, and so forth. And that, so what happened next? How did we go about getting this questionnaire done, and how many patients, doctors took part?
Yeah, we had to develop a protocol, which was a step by step. This is how you use it. This is who we're going to use it on. So we had to determine who had who had enough staff and enough patients in their practice to be able to get a cohort together so that the data meant something. So Dr. Singh's office and Dr. Benamanini, who is his other major counterpart at that address, they stepped up to the plate and agreed to be the guinea pigs for this particular study. So the protocol was written step by step. This is what you do. And we were off and running with 657 patients, I
And
think, in two.
I was going to ask Dr. P that. So, in your clinic, Dr. P, so how many questionnaires? And Linda's told us 657. Talk about the how long it took with each patient, how onerous it was, or if it wasn't onerous, and then talk about what you began to find anecdotally before we get into the actual statistical analysis that we did. Anecdotally, what did you find about undertaking this questionnaire, and what the other doctors in your clinic, like Dr. V, made of it?
So when we started the questionnaire, it had more questions initially than we have now. And initially, of course, there was resistance. The staff did not want it, patients did
Yeah.
not want it. But me, when I looked at the first questionnaire that had been answered, it light bulbs went on because I could see almost a cross section of everything that could be leading to that endpoint. So if a person was using a walker, if a person had a fall, if a person had been exercising, all those questions that were there that could potentially create a risk for a fall. This was almost as if we are having a separate visit within the visit. And for me,
Yes.
it was enlightening, and suddenly I could focus on that. And obviously you cannot remove all the problems that are giving rise to the high risk for falls, but in several of them we could identify clear issues and take care of them. The biggest issues in our population is lack of awareness. Families and patients, they think it's fine, it's okay to fall. No, it's not okay to fall. We can
Mm.
prevent it. We can work together to fall. And it was fun. I tried to make it fun, exercising with the patients and doing those uh, going up and down, getting out of the chair, or what we call pulses. You put your hands up and you're going up and down, and patients like that doctor to be involved. But I think it was helpful. And then we realized we are underdiagnosing or underestimating the problem. And there are significant neurologic issues in our patients that we do not pick up normally. Because when we come into the room, as Linda said, they're sitting and we do our whole exam, unless we make them get up on the exam table. And that itself is a huge part of the exam, getting up on the exam table. And if you
Yeah.
just make sure that they're not using their arms to get up, that is a very enlightening moment for us. And then, the what the strangest part of it is, the weakness of the legs, which can be age related, but caused by clear factors like neuropathies, like spinal injuries, like deconditioning, or certain issues in the spinal cord being compressed, or the nerve roots being compressed. 10 to 15% of our patients have it. 10 to
Or how
15%.
about the things that are caused by other diseases? I mean, your diabetic neuropathy,
Yes.
your Sjogren's disease. We
Weakness of
never
the
looked at
legs,
those.
what we call
Yeah.
paraparesis, 10 to 15%. So, first of all, identifying the problem and then pushing to remove whatever factors you could and trying to alleviate in a simple program of exercise. And the other remarkable thing was some of them, within a matter of 3 to 4 weeks, they improved almost 15-20%. They were
Let
getting up
me
out of the chair without any help. They were doing the exercise with me. They were doing pulses with me, and they were all excited. And that's what made it worthwhile. So suddenly,
Dr. P, let me come on to the success stories because I still want to really make sure that we understand the effort that went into this, the organization and effort that went into this, led by Lynda and Nurse Lynda and others, including your university, Vedere University, where some of the work went into the forming the questionnaire. How so you started getting these anecdotal evidence about what could be done about fall prevention and what the problem was in your population. Over what period of time? Two questions really. Over what period of time did you undertake these questionnaires, and what happened when the questionnaire, that period of time came to an end? Did you stop looking at fall prevention when that period came to an end? Both of you, maybe we start with Nurse Lynda. What happened when that
No,
study came to an end?
no, we did not stop. We continue to look. We don't use that particular questionnaire because we don't need that kind of data. We're no longer doing a longitudinal study. The study is on that first cohort of patients, but we still need to, for every patient, we still need to risk stratify them for falls. You don't just stop. Once you discover that you found a way to bring a patient a better lifestyle, a better health outcome, you don't stop. You can keep doing it with everybody. Some you can help and some you can't help, but you can't fix what you don't know is broken. So you have to ask. You have to do it. So we use a different one now.
So it continued. It continued.
Absolutely.
So okay, now Dr. P. Now, Dr. P, this is the bit I know you're very excited about because you keep trying to answer it when I'm asking you other questions. So, what difference did it make in the lives of your patients? Talk to me about some of the success stories about the difference it made to your patients.
I can give you anecdotal evidence. I do not have statistical confirmation or validation, but I know that several patients started paying attention to their overall health, and families started getting involved. And again, people who thought nothing of getting over a chair to fix some chandelier or some light, suddenly they realized that this was not as so smart. Forget about getting over the roof and try to fix. And you can't believe 80-year-old patients getting on the roof and or trying to fix the gutters, and it's mind-boggling. But those are things that came to light, and we tried to put an end to that. I threatened them with my SWAT team that would reach their homes and confiscate all their ladders and stools and anything above 2 inches that they can step up on. I told them my SWAT team will go there and confiscate and then bring them over. And
You added some humor. You added some humor and a human touch to the whole process, obviously.
this
Of
was
course.
fear-based medicine. Don't tell anybody else, but sometimes you
Yeah,
just
yeah.
have
I'll
to
keep this
practice.
podcast very secret. Don't you worry. It won't go out anywhere. Yeah.
Yes, never tell that the doctor used a hammer to shove it
Or if you
down,
don't
to push.
behave, I'm going to tell your son. If you
Right.
don't behave.
That's right. All those
Yeah.
threats, blackmails, this standard practice, and I recommend it highly to all
So
aspiring.
I hope your patients. I hope I hope your patients appreciated your humor. And well, I know that.
They
I
do, they
know they
do,
did. Yeah. Yeah.
and so we have to have that approach, and I think because otherwise it becomes too serious. but you exercise with them, you go over things with them. They know you care. They know you want to prevent falls, and it's important because one statistic I share with them: 40% of fractures do not return home. And I threaten them. You want to be in a nursing
Mm.
home, laying in a bed, no one caring for you, in a pool of you know what,
Oh,
and
marvelous.
with
What a great
ulcers,
picture
bed
you're
sores,
painting there.
pneumonias, go right ahead.
Yeah.
That if that doesn't have an impact, nothing else will. Suddenly they start
So,
paying
so,
attention.
so at that point, and let's stick with you, Dr. P. At that point, um, let's just understand. Let's for the audience to understand how serious falls are in the US. Give us some statistics. You gave us one. Give us some statistics about how serious falls are in terms of the quality of life for patients and the burden on the state.
So by the age of 75, actually by the age of 65, 1 out of 6 to 1 out of 10 people will have experienced a fall. By the age of 75, 50% of patients have experienced a fall. This is one
Wow.
study. There are different studies, and CDC brings out. Now, as our patients become frail in mind, in body, with 100 medications going on, they lose focus on what are the most important things, and I'm talking about very basic things. So that brings me to their buttocks, and I'm sorry, but don't tell anyone. My focus, I tell them, my focus is your butt. I want buns of steel, the most important muscle in your body. Now that you're 80, all those muscles that you thought were important, forget them. Now we are back to the basics, and it is your gluteal muscles. We need to strengthen them. And so we focus on that. And I can tell you that if they can work on it and if they can prevent a fall, the quality of life, being in your own home, living independently, simple things like going to the kitchen and getting yourself a glass of water, simple things, simple joys of life, going to the yard and say plucking from your plants or growing your plants or getting down to the ground and doing something and getting up, those can be sustained. If they've had a fall, I tell them 10% of falls will cause a grievous injury in some studies. 10%. Think about it. So
Yeah.
5% of the population a year can have a grievous injury. Now, if we can bring it down, the one of the biggest problems in our health system in our population is not heart, not cancer, not strokes. Yes, of course they're important, but something that we all can focus on. So,
Mm.
Lynda, you might have better data than I since you are an expert in that. But at least I can tell you that I think, and I don't know for sure, about 5 to 10% of my patients have started taking it seriously, and I think we have reduced the number of fractures or falls by about 5 to 10%. But we have to do a proper study to confirm it.
I mean, that in alone by
It
itself
takes
is
time because
fantastic.
it takes time because you did the original stuff, then you have to follow them through. You've given them a set of instructions, whether it's to do a safety checklist in the house, pick up the clutter, night lights, the whole 9 yards. And the CDC makes that checklist. There's a lot of education that goes to the family and the patient when this visit is happening with Dr. Singh or any of our doctors, because they're all doing it now. There's a lot of information that goes to the patient and the family. The ones that buy into it, the ones that actually take the time and take it seriously because they want to live independently, they want to have the best, outcomes, health outcomes. Those people, even if you prevent one fall a day, I mean, 70,000 patients, one fall a day is a lot, but it takes
Yeah.
time. So we know we did that. We did the questionnaire. We came up with interventions. They were different for different people depending upon what put them at risk. maybe they were deconditioned, but maybe they had a neurological problem, or maybe whatever it was, maybe they were on the wrong meds. We had to look at it all. And there are different interventions that you use for the different problems. So now you put the intervention in place, now you have to wait and see what happens. Then maybe you have to adjust the intervention and wait again and see what happens. So it's a longitudinal thing. We started, I think, in February. I don't think we've gone far enough to get the kind of data that we actually really need at this point.
Lynda, I was just saying, it sounds like we need to do a follow-up study. But let me change tack. So talk to me, Lynda, about it wasn't just the patients you were dealing with. You were again through Vedere University. You were doing some training. You designed some training, which we could give to the doctors about educating them about fall prevention. Talk to me how that came about, and be very honest. Was Dr. P being impatient again about getting it done?
Yeah. Oh God, yeah. Do it now. Yesterday. No. I want it done yesterday. Get it started. Do it.
Yeah. I think we need this. It's one. We need this on camera. We need this on camera because he just denies it.
Exactly my point. That was nothing. Just do it yesterday. There was no emergency. I didn't say do it last year. I'm not sure.
Oh, you wanted it now. Now.
Anyway, it's on record. Lynda, we did it. It's on record.
I'll show you the email.
Lynda, it's on record. But now, Lynda, just talk us through the training that you did, how you did it, etc., and I know you had some help from somebody called Colin. As well, who's at the university. So talk us through how that went about.
So we took the assessment and the protocol, and we created a learning management system actual course where all providers, whether they were mid-levels or doctors, everybody had to take this course, and in the course was the assessment and an explanation of how to use it and why to use it, and the protocol, which walked them through all the steps, how to risk stratify, looking at the meds, looking at the patient, doing the exam, the different tests, all of it, all the way through, maybe possible referrals to case management if you had a patient that needed to be followed a little more closely, all the different steps. There were like 9 steps. And so they had the assessment and the protocol, and then there were tools. There were support articles that we had pulled down. We didn't just make this stuff up. We took, from the government and from specific sites that we use for our teaching. So there were tools for the providers, but there were tools for the patients as well. And all of that was on the learning management system, on the LMS. And so when they went in to take the course, they saw the studies, they saw what they had to do, they had to take a quiz and pass it in order to, get the, yes, you're finished, congratulations, you did this training. But that's where all of the tools for the patients also live. So there are exercises for chair exercises, bed exercises, logs to send home with the patient so that they could tell you exactly what they did each week. There was the safety checklist. There were brochures and things that could be given to the family. So all of this is in folders within the learning management system. And as they took that course, they got all those tools.
How many people have been through the course?
There are 12 left that have not been through it.
So 110.
So 98.
Okay. 98. And in addition to the doctors, admin staff as well?
The admin staff got the tools because they need them to be able to print them out for the patients and stuff. But what was mandatory was every provider, because we want them to do that assessment. We want them looking at certain things.
Yeah. Brilliant work. Your impatience was the tour de force behind this piece of work and its continued success. What next? have you done enough, or what else do we need to do with fall prevention?
We need to go deeper in our education of our patients, our doctors. We need to be better with the data. Patients who are getting admitted to the hospitals with falls. We need to have those who are very high risk for falls. We need to be able to evaluate their surroundings, their homes, and exercise programs, maybe better teaching of case managers. I think there is more that we can do for our communities and our families and friends and our patients. And every fall, if you think about it, every serious fall disrupts not only the life of that patient, but disrupts the life, causes tremendous ripple effects in the lives of the loved ones, friends, neighbors, and of course the patient.
Mm.
So this is just scratching the surface. I think if we can create it as an integral part of healthcare, our services to our patients, and if we can improve, we can have a remarkable impact in the whole community's health, not just our patients. And exercising is just a great thing because
Mm.
it not just reduces falls. Falls is just an endpoint. You are going to try to improve their stamina, their muscle, their attitudes, their depression, their over medicated regimens, their communication with their own families, with their doctors. I mean, this is a worthwhile endeavor, I think.
Mm. Linda, you were trying to say something.
It's
Did you have
like I
something to
said
add?
before,
And
it's a
because I have some other
gateway.
questions I want to get to as well.
Yeah, quickly, real quick.
Explain what that
As I
means.
said before, when we
Explain what
first
that
started
means,
this,
because
it's okay. So we looked at underlying diseases. We looked at the medications they're on. We looked at their feet. We made them take their shoes and socks off. They would complain, but you have to, you're built from the ground up. If your feet are falling apart, chances are the rest of you is going to fall as well. So when I say a gateway, the next initiative that we're going to bring out, and we'll probably talk about it in these podcasts at some point, is substance use disorders. And where did that come from? That came
yeah, we
from the
certainly
fall
will.
risk assessment,
Yeah.
where we will do one on major depressive disorders. Where did that come from? It came from the fall risk assessment. We will do one on dementia. Where did that come from? The fall risk assessment. All
Yeah.
of the things. This is why I call it the gateway, because everything else comes from that. There's a lot of initiatives
So,
that stem from what we found in the fall assessment.
so basically, the fall assessment work that was done has given us a prioritization of what we should do next. The information that we gleaned from those questionnaires, anecdotally and in practice, we have things to follow up on, but not only things to follow up on. It's prioritized what we should follow up on. Yeah. Um, Dr. P, I want to talk about technology. I know with Vedere University, we're looking at some technology solutions, AI solutions to this sort of thing. Um, talk to me about how technology can. You talked about anecdotally. You think 5 to 10% of your patients have prevented falls that you know of. It's anecdotal, but you're a professional. Anecdotal data is good data. What are the technology solutions that we're currently working on that could really help with this with fall prevention go further?
I think the first thing is good data, getting our data together, and to be able to track our patients' risk factors better, and then to be able to correlate them with what they're undergoing, ER visits, fractures, falls at homes, to collect that data, to trend it, to see how efficacious our interventions are. and
Hmm.
then be able to at some point create
Yeah.
predictive models using advanced analytics, and to be able to create educational material for patients, which remind them, which track them, which make sure they're exercising daily, and creating kind of calendars for them, and then reassessing their strength, their improvement. And so as technology becomes more prominent and as we adopt it, one of my dreams is we create, IoTs, Internet of Things, to track our patients. And just like you have little monitors that watch your heart rate or oxygen, you have
Blood
monitors that
pressure.
track how much exercise you have done and how your muscle strength is. That one very simple thing that I would like to tell you is a
Please.
simple test for me. If a patient comes and you want me to tell you how long, what is the prognosis? How long do you think the patient will live? The best test in the world right now is not a
No
CAT scan,
idea.
it's not an
I'm
MRI.
intrigued. I'm intrigued to know.
It's asking them to get up out of their chair, pick up something from the floor, and get back to the chair in 7 seconds. And it's called appropriately get up and go.
So just explain that again. So the are you saying that the best indicator of somebody's longevity is if they can get up out from a seated position, pick something up from the floor a few feet away, then get back in the chair, and if they can do that within 7 seconds, you saying that they're going to have a longer life?
Yeah, think about it for a moment.
You're in better
To be
shape.
able to perform that simple task, what all is needed? You have to be able to follow an order. Your brain has to be there. Your cardiovascular system has to be able to help you carry out that task. Your muscles have to be, and your nerves, peripheral nerves in your muscles, have to be able to get you up out of a chair, go and pick up the thing, pick it up. So hands are moving, feet are moving. There's a focus. Your entire, all
Balance.
your limbs are tested. Cerebellar system, the back of the brain is being tested. Your focus, your ability to follow a simple verbal request, and to be able to come back in, not in 50 seconds, 7 seconds, and be functional, effective, efficient as a human being. This is the best test that I have
Wow.
today,
Yeah.
scientifically, that I can use to say this patient has a great prognosis and this patient doesn't. Think about it, a patient who has such bad lungs that he cannot even breathe and cannot even get up.
Yeah.
What is he going to do?
Well, when you say it like that, it all makes sense. It all makes sense when you go to the extremes of mobility or a lack of mobility. It makes sense. Fantastic. Let's just go before we're rapidly running out of time. I want to just go back to technology, and you talked about monitors, wearables, tracking health. How far away are we as a group from achieving that? Do you think, and also the predictive analytics? How far away do you think we as Access Vedere? How far away are we from doing that?
We're not too far. If everyone had the sense of urgency that I that they can pull all the data together in the next couple of hours
Yeah.
and start tracking
Right
everyone
now.
and
Right
doing
now.
everything
Now, now, now,
right
now,
now.
now.
Yes.
Okay. Well, I think we
Now.
better bring
Now,
this show
now.
to a
Not
close for
then
two
now.
reasons.
Now, now.
One, Nurse Linda, you've got to go and do some work apparently, and two, we're at the 40-minute mark. So, Dr. P and Nurse Linda, I want to thank you. Dr. P, you're going to be a fixture on this show every week, so you can't travel. Do your exercise on other days. Do your standing up out of a chair and picking something up on the other 6 days. And Nurse Linda, you're going to be a guest most weeks. So make sure you get some carry on exercising so that
Oh,
we
I'm
the
the old
audience
one,
can't say
remember?
anything negative about preaching. So, any final key takeaways, Nurse Linda? One key takeaway from you from this week's podcast.
Ah, well, I'm going to be 72 next week. So I build sets. I got scuba certified when I was 70 years old. I travel. I go to the gym 3 days a week. I'm the one that does do all of that stuff.
Good job.
I'm living
Good job. That's
proof.
a
I'm
great
living proof.
key
So
takeaway. That's a great
it's
key
my key takeaway
takeaway.
is
That's
keep moving.
that's
Keep moving. What you don't use, you lose.
keep moving.
Period.
And thank you, Nurse Linda. And Dr. P, what's your key takeaway?
Key takeaway is my patients need to, for everyone, is to watch your backside. Don't let the muscles go down. When men,
Wow, that was
I'm
so
putting it
medical.
delicately.
That,
But my
High and
patients know
tight.
how interested. Linda,
that's
you've
very
you've
delicate.
been. They all know. I want to look at their butt so that the skin, there's nothing broken, no decubitus ulcers. I want to make sure that their gluteals are strong and they can get up without a problem. I mean, my patients think I'm the sick puppy, and they make fun of me. But I they
So your
but
key
they,
takeaway, Dr. P, if I can just help you out here, so on screen here, your key takeaway is keep your glutes strong. That's the muscle that matters when you get to a certain
the
age.
most
Don't worry about your
important muscle.
biceps. Don't worry about your biceps, your triceps. It's the glutes that matter.
Yes.
So and my key takeaway from this week is that we need to get our predictive analytics sorted out rapidly in the next few weeks, months, so that we can improve on that, helping the 5 to 10%, and just improve that the universe of patients that we can really help. So, Dr. P, Nurse Linda, thank you. And we will see you next week when we will be talking about Medicare risk adjustment, which
Right.
Oh,
Nurse Linda is also an
yay!
expert at.
Yeah. Remember the glute of a brute. That's what my patients remember. All of them.
Glute of a brute. There
Okay,
you
with
go.
that, with
Glute,
that,
glutes of a
it's
brute.
goodbye from Dr. P, and it's goodbye from Nurse Linda, and it's goodbye from me. Goodbye.